Today's guest can be summed up in one word, and that is disruptive. And I mean that as the highest possible compliment.
Absolutely. And Dr. Lauder really proves this in the fact that she's truly integrative in her practice. We touched on chakras, a time and a place for pharmaceuticals, ozone therapy, and more. I think it's a very valuable listen, and I think you'll enjoy it. So let's tune in. Hello, and welcome back to the Vibrant Wellness Podcast. I'm Dr. Emmy Brown, here with my exceptional co-host, Melissa Gentile. Today, we have a truly inspiring guest, Dr. Mary Lauder. Dr. Lauder is a double board-certified osteopathic physician specializing in integrative medicine and family medicine with a profound commitment to guiding patients on their journey to health and wellness. With a career spanning over 3 decades and an upcoming book, Dr. Lauder has dedicated herself to not just treating disease, but finding and nurturing health. She believes in the body's innate capacity for healing and emphasizes the importance of connecting with oneself to achieve true wellness. Join us as Dr. Lauder shares her unique insights on the doctor-patient relationship, the power of understanding our emotions, and how the journey inward can pave the way forward. Dr. Lauder, thank you so much for being here.
Oh, you're welcome. It's a pleasure to be here. I'm looking forward to this. I've looked forward to this for quite some time. In great
Good.
anticipation. Yeah.
We are too. All right. So let's kick it off with a little bit of a history on your background and how you got to where you are now. I'm wondering if there's a pivotal moment or something that comes to mind that led you to pursue a career in osteopathic medicine and really an overall career beyond the traditional medical model. What inspired you there?
Yeah, many things. But I think the main thing was my advisor in college, my freshman year at the University of Montana, go Grizz. He said, you should be an osteopath. And I said, oh, no way, they're quacks. That was the first thing out of my mouth as just barely 18 years old.
Wow.
And he said, well, but you line up with everything that osteopathy has to offer. I go, nope, they're quacks. Sorry. So then fast forward a number of years, I got my degree in athletic training, sports medicine, worked in master's degree in spinal biomechanics. And I was at Michigan State and they had an osteopathic college. And one day I said, I have to be an osteopath. I must be an osteopath because I was studying the spine. I was studying movement. I was studying wellness. And, I looked back over my, at that point, slightly illustrious, but very short career. And I realized I wrote studies on and research projects on Laetrile, on patient choice, and how the body can find its way to heal. I had no clue what I was saying at that age, but those were my beliefs.
Yeah.
And then I realized I must be an osteopath. And so I applied to one osteopathic college and I got in. And they said in the interview, they said, well, if you don't, get in, what are you going to do? I said, well, see you next year. So I was just planned on being like a piece of furniture, staying there.
You were committed.
Yeah. Yeah. So, and the funny thing was craniosacral is a component of osteopathy. And we learned osteopathic principles and adjustments and treatments. And I was all in on that because when I worked in a physical therapy clinic, I would treat the patient by evaluating them. I would go back to my osteopathic textbook. I'd read the textbook, and then I'd go while they were on hot packs, then I'd go back in the treatment room and treat them, and they got well. And so then I would call their doctor and say, hey, they're better. And they're like, what are you doing over there? I go, osteopathy. And so when I had an interview, I had an interview with the dean of the college, and he said, well, what do you think of craniosacral? And at that point, I really didn't know much. And so I said, well, between you and me, I think it's voodoo, but I'm open. And so
if it works, right?
Exactly. So, and as it turned out, we got trained in craniosacral, and I actually, excelled in that. And I thought it's actually not voodoo. And so it's just a wonderful treatment modality by understanding fluid mechanics and how the body's wired and inherently has the capacity to heal. So it just lined up with all of that.
Dr. Lauder, I I do have to ask, when you were treating patients in the physical therapy facility there, what kind of conditions were actually getting better with like the hands-on physical treatment? Was it just like joint pain or muscle tension, or was there like, digestive issues? What was it? Was it more than just fascia?
Well, it was the fascia and the intestinal issues were secondary, and I didn't know why that got better because I didn't have the understanding. But what I did is I treated a lot of sacral dysfunctions, which would then have its play into the pelvic floor, also low back, diaphragm, and there's 5 functional diaphragms that we work with. And the biggest thing was, let's see, it would have been the mid to late 80s. So that's when it was. Spinal surgery was a big deal. You have sciatica, you went and had surgery. Well, the folks would still end up with the same symptoms post-surgically.
Mm.
So I'd go to physical therapy. So I would do a pubic bone adjustment, a posterior sacral torsion adjustment, rotated L5 and a group curve in the thoracic area, and their pain went away. Their sciatica went away. The thing they went to surgery for went away. And that's what sold me. I'm like, oh, I get it. This is structural and it's all kind of falling into place. And so that was, to me, one of the most astounding things, that people had gone through a surgery and hadn't gotten relief. And it was interesting because in the literature at that time, it was really a big push to do a lot of spinal surgeries. And as a result, over that period of time, the data came through where now we wait, 12, 18 months and things settle down. And, sciatica and even disc disease has its own really pathophysiology of it, inflammation and then coming back from inflammation if we give it time and treat other things. If it's really, truly just, at the nerve root itself. But because it's chronic, it's multifactorial, right? So it's not any one thing. But usually if it's an acute trauma, you could see an injury to that area. Yeah.
So that physical medicine really kind of push you towards osteopathic medicine. It sounds like
it did.
Right, your skepticism to begin with.
It did.
And I want to pivot a little bit here, Dr. Lauder, and because I'm so excited to hear about it. Your upcoming book, I'd love to know about core themes. What can readers expect to find here?
Right. So it's in its final stages right now. And it's really a collection of lessons that I write, like a fable in some aspects, but looking at it, the title is A Fabled Life, Stories and Lessons of a Physician Healer. And what I realized as I've been in my career for a significant length of time and been in life long enough is the things that I am now and really seeing that I want to bring forward in my career are things I always was, even as a kiddo. And that connection to self, that connection to nature, that connection to the inherent healing capacity that we all have. I believed that as a kid. And there was a lot of behaviors I had as a kid that were seen as quirky or unusual, but that's just how I was. And really what it was all along, I was this little healer kid walking around, just living my life and really communing with nature. And so it's really connecting back to those roots in my life and seeing how I've really pulled all of that through. And then some life lessons that we all get to go through because, no one gets in and through life without a few of those, right? The goal is for people to be inspired, for people to understand that they can transform and that they can have innovative ways to reconnect with themselves, because that's the safest place to be, connected to ourselves. Yeah.
I love that. I really, really love that. Connecting to yourself and connecting back to nature. And it's such an innate thing for you. It seems like it just comes so naturally, especially with you growing up the way that you did and how connected you were just as a child.
Yeah.
I wonder, Dr. Lauder, do you feel like that got lost as you grew up and we become conditioned with societal expectations? And I think a lot of us have to really think back. It's an active process. It seems that maybe it shouldn't be. As you mentioned, Melissa, it seems that it comes very naturally to you, Dr. Lauder. But was there a point where you had to say, I need to go back and think about what I was gravitating towards as a child and what really made me feel
Yes.
one with myself as a child.
Yes. And I think, for all of those reasons, the conditioning, things you're supposed to do, responsibilities, what you're supposed to look like. Even, when I was an osteopath, I was always slightly unusual because I was just like, well, why? Well, why did that happen? Well, why did that happen? Till finally they said, just quit asking those questions and do the treatment. And I'm like, well, why? So I've maintained that, but it actually, there were times and there were things that I had to learn to, where people were very unfavorable. Without being a victim in the story, they were hugely unfavorable. And I had to really heal from a lot of that where people misunderstood me. They go, we just don't get you. Like, okay, and so that created times of sometimes being lonely, sometimes feeling, out of the loop. And I would say, in the traditional world, I would fit to a certain extent, but then after a while I wouldn't fit because I would always have different ideas. And what if we tried this? And what if we, took more time with the patient this way? Or what if we brought this in? And, and so as medicine changed and the constraints came down more and more, that became much less inviting to be that way. And it became much less accepted. And then so that was disruptive. When that was a word that was used, you're kind of disruptive to our 32 patients in and out, 10 minutes and, antibiotic here or cream there. And I'm like, well, maybe we should figure out why they're irritated.
What else? Yeah.
Where do you see gaps in the traditional medical model? You touched on it a little bit already, but then also, like, where are you seeing gaps in even the integrative and like functional side? Because some of these integrative and functional practices, they're still having kind of that allopathic approach where they're just switching a pharmaceutical for a supplement, and that's still not really working for us. So I would really love to hear kind of your thoughts on that there.
Yeah. Now you're reading my mind. So awesome. We're reading each other's mind. So the gaps in the traditional care came from the pressures of the insurances. And without getting political, we see huge profit margins, and then restriction of care. And then the prior authorizations being required, and then requests for tests being denied and care being denied, and people losing their homes, their livelihood, and different things because of medical debt. So we've got to solve that. Must be solved. And, my personal feeling and my professional feeling is we need absolute universal coverage, period, in this story. Okay. We're going to leave that. I'm not going to go down that trail, but that's really will solve part of that. The other gaps I see is communication, because we have so many people that need to be seen in such short periods of time. I mean, think of the efficiency. You drive 20 minutes one way to take 10 minutes to check in, to sit in a waiting room for 45 to 50 minutes, to go back into a room to sit for another 20 minutes, pretty much with nothing on or not too much on. And then the provider comes in and they have 10 minutes with you and they're looking at a screen, not talking to you, not listening to you. They don't examine you. Stop me where I'm wrong there, but they don't examine you. They don't touch you. And then they hand you a paper for tests and labs.
You're right.
Yeah. I mean, that's the model, right? And then we have the model of where we have mid-levels that are not supervised. Now, I have tens of thousands of hours of training. That was coming out of residency. They may have 1,000, 1,200.
Oh, wow. I didn't realize there was that much of a gap difference.
Yeah, it is.
Okay.
And they may have online school or in person. So, there's this old adage, you can only diagnose that which you entertain, right? If you've seen it, and the osteopaths have this thing, see it once, do it once, teach it once. That's how, so are we thrown to the wolves? Not so much, but you learn by experience. And so, but when you see something, you learn. And then you would go to the literature and you would go to your textbook And then you would go back to the patient and you would observe, you would treat the patient, then you would go back to the literature, then you would discuss it. So that depth of understanding and learning was there from those many hours of training. That doesn't happen now. And sometimes in medical school, that doesn't even happen. And because the nature of things have changed and the hours have changed. They talk about the long hours, good and bad. There's two sides to that coin. Yeah, no, you don't need to be exhausted. If you can sleep if you can sleep anywhere, you can survive, which I could. I could sleep almost standing up. And so I did well with, varied sleep and lots of hours, but not everybody can. But that doesn't mean we make it bankers hours either, 10 to 4. And you just aren't going to see the stuff. You aren't going to see the things you need to see. So seeing things that are basic pathophysiology that you learn from and see and work your way back by understanding a good exam, really understanding a physical diagnosis. So then, and taking a good history, listening to the patient. If you listen to the patient, they will tell you what's wrong with them. They will. Then you examine them, and then you're going to find something that's consistent with their history, or you're going to pick something up. Or if you have any sense of intuition, you touch them somewhere, they're going to come out with a story, right? That somato-emotional component, right? And if you're tuned into that by just taking your time, you aren't, showing up as woo-woo, but if you just take your time, something's going to come out. Oh, yeah, I remember. Oh, okay, well, that's important information. Then you order your tests that will confirm or rebuff that which you think the patient has. And then you provide next steps in treatment and care, and on it goes. And when in doubt, go back and re-examine. When in doubt, go back and retake the history. If you do that, you won't miss anything.
And this is how we're trained, Dr. Louder, but it is getting missed, as you said, more and more. The physical exam is falling by the wayside. And I can only imagine what you have to say about completely virtual practices.
It's good if you're an intuitive like me. I'm an intuitive, but also 30 years being an intuitive, right?
There's a way.
Yeah. So I wouldn't recommend that to start out. So, and there are people who are medical intuitives that are pretty accurate, but then you need to then confirm that which you intuit. Yeah. You need to find the test for that. And that's the same thing. Like people talk about kinesiology, love it, hate it, both, right? Because you've got to confirm that which you're finding. And if you're finding it energetically and it's really interfering that much in the energy field, you're going to find true symptoms, which is what the patient experiences, and then signs, which is what you see on the body. Yeah. Sign could be sweating. It could be a change in pulse, could be change in blood pressure. So you put those things together. So you use that intuition as a tool. It's not the only way. I think virtual can work for simple things, and it can work for emotional things. I think it can work for follow-up for chronicity, but not for initial diagnosis, because you got to do all the above.
Right.
And the component of my practice that's virtual is after they're established, after we know what's going on, or if we're doing only emotional work.
And I want to talk about spending more time with patients now, Dr. Louder. Obviously, to gather all this information, to really understand our patients, we need to spend more time. And I'd love to talk a little bit about the controversial issue of cash pay practices. Obviously that is what a lot of our functional medicine practitioners are turning toward to accommodate these longer patient visits. What are your thoughts about transitioning to a completely cash-based practice? Is there a hybrid model? Do you accept insurance? What advice would you give to other practitioners? And really just how do we accommodate longer patient visits for best outcomes?
Yeah, that's a super good question, and it has a lot of caveats to it. So I love that we're going there. First off, when a physician or provider is in the insurance model, they lose control. The patient loses control. So if we take that word control and change that to sovereignty or informed consent or informed refusal. That kind of sounds a little bit different, but they lose that ability for ultimate choice making. I mean, surely it's still their choice, but the patient in an insurance model aligns with what their insurance will cover. And that's the limitation, which often doesn't go far enough. And we know that in the functional world. That's why the functional world is exploding now, right? So there's that. The physician knows that there's restrictions on what the insurance is allowed based upon diagnostic codes. And so those diagnostic codes have exploded. And so treatments in some worlds have exploded because there's more description of what types of illnesses we have based upon diagnostics, which then only serves to provide better reimbursement.
Mhm.
So what are we chasing?
Mhm.
None of that has to do with healing, right? So I take issue, and I do have ethical issues with insurances. So after many, many, many years of being in the insurance world, out of the insurance world, in the insurance world, I finally left the insurance world for good. And I had to go into a micro practice to control the overhead. The margins in practice are very slim, because it's service oriented, it's fee for service, it's the more you do, the more you get paid, which I don't exactly think is a conflict of interest because you're providing a service. They're there for a service. So I don't see that as a conflict of interest. But I do see it as turning into a mill that you just go faster and faster and try and do more. So, ways to look at that is to consider group visits, packages, and things like that. So it's trying to change the paradigm of what becomes valuable for the patient.
Mm.
Where do they want to invest? Do they want to invest in their health? I mean, because we know if we have all the money in the world and we don't have our health, what's that about?
Yep.
Right?
What's the point?
If we have 5 houses, 4 boats, and 3 Mercedes, and we don't have our health, right?
Mhm.
So we already know that, but we don't live it that way. And we don't prioritize our health because we prioritize our cars and our homes and our possessions. But then when it comes to our health, well, it should just be free. And, I think the hardest thing to hear is, well, the doctors are making all the money. No, we aren't. And I will tell you that if I were an employed situation, I would be making the same this year as when I first entered practice 30 years ago.
Mm.
Show me an industry where that's happening. Show me an industry where we've got this many regulations of what I can and can't do. Can't have a pen or a mug from a drug company because it's going to influence me.
Mhm.
Now, that's just silly coconuts when we've got all these lobbyists and we have all these people in Washington, doing things that are backwards. It just doesn't make sense. Now, is there corruption? Yes, because wherever there's people in power, there's those opportunities. Is that the majority of physicians? No. I think the majority of physicians and providers are actually healers, and they're trying to use their modalities and training to heal and to help.
Yeah. The good intention is there, but the pressure is also there.
Right.
Yeah.
And I do also think that it's great, and we should be able to make a great living. Why? Because we're doing one of the coolest things. We're helping people get well and stay well. Right? We aren't selling widgets. We aren't selling thingamajigs. We are helping people live their best lives.
Extremely valuable.
Exactly.
Yeah. You're extending people's lifespan, and you're giving their health and vitality back. And I mean, that's priceless.
It is. And so I had to go away from the insurance model to exist. My last functional practice, integrative holistic practice, was in Colorado, and I loved it. I had a great private practice. I did IV therapy. I did lots of procedures. I did prolotherapy. I did stem cell therapy. I did PRP. I did ozone. I did everything you could do. It was great fun, and it cost a lot to run that practice.
Sure.
and we did it well. And I didn't make a lot of money. My staff lived well because you needed good staff to stay, right? And my patients had appropriate fees. And then COVID came, and literally we were shut down. So we were seen as non-essential.
Mm.
And then literally the pandemic, like happened to many people, but I lost my practice in a pandemic as a physician.
Mhm. Wow.
And they said, well, here's a loan. You could come back. I'm like, no, no way. So, because you couldn't go back into that model
Yeah.
to be disrupted and to have literally no control over your business.
Mhm.
So, it's a model that's not sustainable to go by insurance. And the only way you can do that is if you're in a large system that feeds the system.
Mhm.
And this is nuts and bolts talk here. This is brass tacks. This is, we're pulling back the curtain and we're probably showing a bit of the underbelly, all those things. This is
It's
not,
important.
yeah. And it's
Not-
important to understand that. So I think, and then I've seen the other side of it where in both, well, has been primarily the integrated functional world, things are super expensive.
Mhm.
$3,000 for the initial visit, $5,000. And I'm like, okay, that's a bit steep. And, what are you getting for that?
Mhm.
And so, to get away from the fee for service, I went towards a membership and offered two arms of the membership. Everybody comes in the same door and we do genomic testing. They get an initial visit and a follow-up, health coach visit and a follow-up, and the genomic test with the results. That sets the stage because that's a blueprint for their health.
Mhm.
From there, they can go into the direct care model, which is a la carte, or the gold standard, which is concierge. Depends on their needs. So we meet their needs and we make it affordable to meet their needs once they're in. And so then what I'm going for is the loyal patient, the engaged patient, the patient that wants to work with me, wants to get well, wants to do the things. So that's a different way of looking at the problem without overcharging and yet bringing a solution and yet maintaining the value. And then my office is a small office. My staff is virtual
Mhm.
and we use electronic means of communication as well as in person. So I'm able to control and minimize the overhead.
Lots of clever things in place there. I think this will be very helpful for our listeners.
Yeah.
And you mentioned a health coach in your practice, Dr. Lauder.
Yeah.
I'm sure that practitioner is extremely helpful, especially when we're talking about longer patient visits. And even if you offer, a 90-minute, I'm not sure what your initial consult is as far as time-wise, but there's more questions. There's always more questions when we're really diving deep into understanding our health and the education piece. So I'd love to know, how does your health coach function in your practice? Do they help your patients understand the functional medicine labs? What advice do you have for other practitioners in terms of health coaches?
Yeah, they do. So first of all, they do. Second of all, I scored a nurse
Yay!
who which was great because she's been a nurse for 31 years and she gets doctors, which is really helpful because we're a unique lot. And she has also been in charge of offices and in charge of nurses.
Mm.
So, and she wants to be a health coach. So this is great. And she wants to be on the healing side of things instead of just trying to fix things or put Band-Aids on it. So it's perfect. So that is super helpful. And so then I can put in the note, needs help on, Mediterranean detox, look at the genomic scores, and then meet with a patient and figure it out with them. And so that could range anything from they want a meal plan or items to eat
Mhm.
to, okay, why do you think you're driven, 3 times a week to maybe overeat or maybe undereat? Or where do you think that stress is coming from? How can we help you stick to what you're wanting to achieve?
Right.
So she can cover really the gamut. And also because she has a background in chronic pain, palliative care, and hospice, it's not like our people are dying, but what I'm saying is that she's got a perspective,
Yes.
right?
Yeah.
That it's not like it's, well, we have to hurry and fix you and everything has to be perfect. It's like, what do you want your life to be?
Mm.
You know? And so as great as this sounds, I would like to submit at this point that 100% of my patients die, just hopefully not on my watch and anytime soon, because we're all going to die, right? So, but the goal is to live well
Yeah.
until we die, right? So I just want to let you know my success rate is 100%. Ah, eventually everybody comes when it's time, but I think that having that perspective is something that gives, we're really coming together as women of a certain age that are able to help patients.
Mm.
And I think, looking at the uniqueness of the female patient, the uniqueness of the female body, the uniqueness of the female labs, and the needs of women at all ages is something that we could do a little bit better with.
Absolutely.
And I'm not a proponent of the biohack, anti-aging. I'm a proponent of aging well and understanding yourself would be the biohack. Who are you? What are you meant to do? What are you meant to bring to the world? What does your genome look like? What is your blueprint? How shall we build according to your blueprint?
Right. And thus contributing to higher quality
Right.
life.
Yeah.
Right.
You can extend your lifespan and focus on longevity, and maybe you live an extra 20, 30 years, but it's like, what are you doing in the time that you're here? If
Right.
you're not focused on that, like, shouldn't that be, kind of the first priority? But and
Yeah.
this part might be more of a question for your nurse, but I'm sure in all of your experience, you can come up with maybe a couple of tangible tips for us. But,
Yeah.
in this field, patient compliance really is kind of like the biggest piece of success and whether a patient's gonna, get better or not. And I feel like in our field, in our industry, more than kind of the traditional model, it's a really big challenge to make some of these lifestyle changes because it's not just taking a supplement or taking a pill. Like we're usually uprooting beliefs and we're changing workouts and we're changing diet and we're changing all of these habitual things that we've maybe been doing since, we were young children. So what are some ways that you kind of help facilitate change in your patients' lives? Like, is it motivational interviewing? Like, how do you kind of instill that spark in them, or are they kind of coming to you already like ready to go?
No, they think they're ready to go until
Mm.
you present to them what needs to
That's the
happen, right?
difference.
So, but you actually, your answer was in your question.
Mhm.
You take them back to their childhood.
Mm.
What were the values they had then? What were the things they were taught then? What were the pressure points that their mom or dad put on them then? So you're going to see how they're going to be wired, right? If they don't feel they're going to be good enough, that nothing they do is going to be good enough. What's going to, so you begin to work with the mindset. So the motivational interview looks more a bit like mindset and connection to self. And where did that, shape some of the beliefs that the person has? And how did that belief pattern repeat itself in life? So that would be one thing. I think the other thing is looking at and understanding baby steps, turtle steps,
Mhm.
1-degree turns. You make 3 1-degree turns, 3 degrees to your left, you're going to end up, a mile down the road, certainly different than from where you are, 5 feet away, right? So that even little turning points can be huge. And I think that's really important. Education, breaking it down, and maybe having them take smaller steps and change and transformation initially until they get used to that. One of the things that they get, faced with is, what is this going to undo in me? Will I even be able to succeed at this? Can I follow it through? And so, that's why I start with the story of who they are
Hmm.
by using their genes. And I can usually then, without meeting with them, tell them about who they are.
Ooh, I love this.
And then when I do, they go, how'd you know that? I said, well, I'm reading your genes. And so then when that comes about, I said, and so the goal would be to work with who you are. And let's continue to support who you are through everything that we do.
Mm.
And so if there's a little bit of repair over here, like if we do a gut test, right? With a gut zoomer, I love that test. That is a plug from my side. Then what do we need to know? Well, here's the categories. Here's it, whether or not there's pathogens. What's the digestion? Is there inflammation? How do we repair that?
Mhm.
How is that going to play into your emotional being? How is that going to play into detoxification? What's the story? So if I can break things into stories and bring a narrative to that and bring them around to their symptoms and their signs and bring that into the story and recreate that story with them and help them with that, we can always kind of have that as the story and always have that as a way to understand without, getting stuck in the biochemistry, the pathways, the MTHFRs of the world and all those types of things where people just get stuck.
Yeah.
Right?
Without a context, as you said, there's no story.
Yeah.
So where's the meaningfulness in this?
Right.
That's what you're really adding in here. I find
Yeah.
that immensely helpful.
Yeah.
I have to ask Dr. Lauder, what kind of genetic tests or specific SNPs are you looking at beyond MTHFR?
Well, there's about 170 of them that we evaluate in a test.
Mhm.
And when we do that, that puts things in categories:
Mm.
detoxification, inflammation, oxidative stress, cardiovascular, vascular, hormones, nutrition, exercise, recovery. I think that might be all the neurology might be a category as well, and behavior. So it gives us curated SNPs that the company continues to monitor in the literature, that the SNPs always have to be grouped. It's never one SNP a disease makes. Never. It's a SNP. It's just a base pair switch, right? And so then you have to go back and understand the biochemistry of that. And then it's not always like with the MTHFR, it's not give people a bunch of Bs, because if they actually show up over here with not as much choline and really not making or absorbing choline, and maybe they have issues with zinc and magnesium, really the methylation is affected by other steps.
You're missing a lot of it. That pathway is
Right.
complex. Yes.
Right. And so then we have to go, okay, what are their symptoms, right? Then from the blueprint of that, I go into functional testing, whether it's a hormonal test or detoxification based upon what they've been exposed to. Maybe we're going to look for a infection,
Mhm.
a vector. And, maybe they've been having all these vague symptoms that nobody can put together. I mean, I had a patient who a year ago was in the ICU and they were in their 20s and the specialist couldn't figure them out.
Yeah.
And the mom called me and said, what do you think? I said, well, I think we need to test her for Lyme. Well, no, they already did. I said, oh, they didn't, but okay. Because I said, it sounds like Lyme.
Mm.
I said, but yeah, I'll be happy to see her. So we were on the, the extensive panel. And according to the CDC criteria, the patient had Lyme and co-infections and viruses.
Mm.
So the vectors were there. And it was very complex. I followed that up with the neural test to look at inflammation in the brain. And there were the triggers that were causing her symptoms. And it was right there. These are standard tests that are put together in a unique way.
Yeah.
These are tests that are curated. These are tests that are available. These are tests that work, that meet certain criteria, and boom, there's the answers. Yeah. So what you do, and they go, well, it must be some weird virus. Well, no, it was Lyme. Titers, the IgM, IgG, they were elevated. All the criteria was there according to the CDC.
So oftentimes it gets overlooked.
Right.
Yeah. Yeah.
So this patient had a first round of testing that it came back as negative. Is that what you're saying?
Yeah, they had a Western blot.
Okay. Gotcha.
But the timing of the Western blot is the key.
Okay.
So how I explain it to a patient is I said, okay, I need my keys. Go find my keys. Go get my keys out of the house. They go, well, I went to the front door and your keys aren't there. Well, no, they're in the house. Please go get the keys so we can leave. Well, no, I looked in the front picture window and your keys aren't in the house. I go, no, Curry, go get the keys. We got to go. Well, I went to the first bedroom and there's no keys. Okay, go around the back, go in the back door. They're on the kitchen table. You just got to look differently. You got to go in differently. Right. They're there, right? So you just got to keep looking till you find it. But it's the window, it's the view into the patient by using tests that give you that window into what's functioning, what's going on. Right. That's so important. Yeah,
absolutely. Yeah,
it's like detective work.
It is.
Mystery is. It really is.
It is. And that was the thing. And then we began treatment with her, and she's had minor little setbacks, but she has not had the relapses. She has not been back to the hospital. She has not been in the ICU. She's completed a year of college. She's, going off to study abroad next year. She's recovering.
Wonderful.
Yeah. She's recovering.
Yeah.
And, and then I treat her in a complex way where we work with the body's inherent capacity to heal, detoxification, plus treating the vectors. If there's an acute flare, we do use antibiotics because that does work for a short period of time, 10 days. But then we're going in deeper because with Lyme, it's in the fascia. It's woven in the tissue. It's in the cells. It's in there, right? It's deep. And so then you use these homeopathic herbal-based products with, a lot of with some glutathione and the body's, and you work with the body's capacity to identify things. And that's why I love ozone. It's got this bioresonance to the cells. And that's something that's in the literature, but it's overlooked. One of the things that's happening now in ozone is they're doing high doses of ozone, 10 pass, and these really a lot. And I'm never a proponent of that. It's little, because ozone finds its way by resonating with the cells. And when it does that, it meets the cell where it's at and bumps it up or slows it down. So it's not blasting it, it's working with.
Yeah. I think it's so important for listeners, practitioners, and other people like to hear that it's not just about one treatment and the modality, but that therapeutic dose, and always looking for that research to see, is it a little bit or is it more that we need for effective outcomes?
Right.
That's
right. And in America, it's always more is better.
Mm-hmm.
So if you go to the European literature on ozone, it's slow it down, lower doses.
Mm-hmm. Oh, it's interesting.
So, and there are some European clinics doing the high 10 passes and the high doses. And I had opportunities to be trained, and I observed it all. And I'm like, my intuition was, nope, absolutely not. That is not the way, at least for me, the way I wanted to do it. And I've had great success by not doing it that way. Mm-hmm. So I didn't feel a need to change. So
always learning. Absolutely.
Yeah.
Mm-hmm.
Yeah.
Speaking of, this is making me think about intuition again, as you just brought that up, Dr. Lowder. I'd love to learn more about your masterclass called the My Anxiety Code.
Right. Right.
And you mentioned on your website, I loved this one objective. It's to learn how to observe your anxiety as something you feel rather than it being how you are, how you're wired. And so I would like to know, how does this relate to, or maybe it refutes the idea of a highly sensitive person? And that concept, for those of you who don't know, was coined by Elaine Aron. She's a psychologist. I find it fascinating. I'm curious about your thoughts and all of this.
Yeah. So my anxiety code came out of a need to reach patients who were anxious and had trauma. And it came out of my learning about how to reconnect with themselves. And when I saw I could help them reconnect, their anxiety was the first thing that went away.
Mm.
And so then I asked them, well, what do you think your anxiety was telling you? And they said, I just needed to know more. And I was like, okay, well, what is fight or flight about? Getting away from, or trying to find, or, or even freezing or fawning. What's that all about? So then as I kind of just thought through all of that, I thought, well, anxiety is just, we're anxious because we don't know. And we just need more information for us to feel safe or comfortable. without being coddled, without being fragile, because we have, for everybody that has trauma, 3 people go towards resiliency and 1 person goes towards fragility or into a trauma state. So it's interesting statistics, just how humans are wired. They're wired more for resilience. So that's something to know. And so then understanding that, I said, how do we figure out what anxiety is? And I said, well, what if it's a frenemy? What if it's a friend? What if we even just allow it to be a friend? And we ask what it's trying to tell us. And it usually would bring up an emotion after that. I feel anxious because why? Well, because if I do this, I will disappoint someone. Then I said, well, what will happen if you disappoint them? They'll get angry. Okay, so we're dealing with 2 emotions. So then I learned about the language of emotions. The more I had language to describe my emotions, the more I could have clarity about what I felt. So if I give you 3 words, happy, sad, okay, and you went to Disney World and I said, tell me about your trip in Disney World in those 3 words, it would be so limiting, right? And if you only had 3, and by the research into emotions, we typically know about 3 emotions: happy, sad, and anger, or, pissed off, as they say, right? So and that's the 3 emotions people land on. But if we improve your language and your landscape of emotions, you can better understand what you're feeling. And then I would ask them, well, where do you feel that in your body? Well, that always makes my heart kind of flutter, or my stomach gets butterflies, or my neck hurts. Okay, so aligned with each of those spots, you're pretty close to a chakra, which is an energetic superhighway, pretty much, right? And you can take the chakra and the energetic meridians and all that into a variety of traditions, right? The osteopaths call them Chapman's points and trigger points. And then you've got the meridians, and then you've got, just everything. So there's just lots you could go with that. But it's a superhighway. It's kind of a collection. Some of that goes back to embryology and tissue germ layers of where things came out of. That's how some of the chakras also came about as well. So it's kind of interesting embryologically what we're connecting with. So then you take that emotion, find that feeling, and then you give it a 1 to 10. And then you find a secure statement. Even though I feel this anger, even though I feel that I'm going to disappoint, or I feel I'm not going to be good enough, I deeply and completely love, trust, and accept myself. I choose to connect and reconnect with myself.
It's like the EFT tapping. Is that
It kind of is. And this is the self-compassion and connection. Because then what you're creating is a biofield, a transference of energy, whether there's a person helping, so there's a biofield with 2 people, or you create it yourself by touching your heart and your solar plexus. And that's like completing a circuit. So I can go over, flip the switch to turn the light on. It does not matter if I use my left hand or my right hand to turn the light on. The switch will flip, right? So it doesn't matter left or right, just the circuit's made. And creating that circuit generates a biofield that you're able to shift the energetics. And then that charge comes down and you're like, oh, well, I see that would be disappointing them, but I'm actually projecting that, and I'm actually more worried than I should be or could be. And actually what my responsibility is this. And so, yeah, okay. And so then they begin to, when that happens, what happens in the nervous system is, instead of flooding up from the body, which really is driven at the midbrain, that shuts off the frontal cortex, which is your higher centers and your administration up there. And your frontal cortex can't give you direction, can't be logical, can't tell you, oh, everything's fine. Last Tuesday you had this, and when you just, put 3 things together, your presentation went fine. It literally can't hear that because so much is flooding up. So those exercises treats that flooding up by processing it into the nervous system, into the autonomics. The autonomics calm down, the midbrain opens up, the frontal cortex comes back online, and you're like, oh, I can do this now. Thank you very much.
Or like how you blend together the emotional piece with the science piece. So it's
right.
It's very grounded. It's not too out there, but it's not too scientific. It's really a nice, beautiful, it's like kind of symphony of both, and how they're really not, separate concepts in the human body.
Truly integrative. I think you have the best grasp I've seen, one of the best grasps I've seen on integrative medicine. So within this hour, it's very clear to see.
Yes,
like
thank you.
Reform everywhere, and it kind of really reminds me of Joe Dispenza's work too, because I feel like he really brings the science piece into it, and I do that really, really beautifully as well.
As I say, well, and patients, the other part of the anxiety was because patients came with so many symptoms and no diagnosis, right? And that is one of the very biggest definitions of medical trauma. Because finally they showed up and they're like, well, they just told me it's all in my head, but I don't feel right. And then we would do the testing. We would literally find the diagnosis, like in those Lyme cases, or like in, other areas, right? Or like in a toxicity or a mold exposure or a variety of things. We literally would find the diagnosis and begin treatment. They would get well. Well, they had all this anxiety because of all the things they were told, how bad they were and what kind of people they were, expecting what and what and what from the traditional system. So I had to talk the people off the ledge, and I had no tools. And that's when this tool came to me after learning through, trauma care and becoming trauma informed. I just began working with patients, and then this component of how I do it evolved. It helped people immensely. And it was like, this is really, really, really important, because their anxiety level dropped and their healing went up. Because I could get them about 70% better, but I couldn't get that extra 30%. We did this self-care and connection and the My Anxiety Code. Boom, 90, 95%. Boom. Mic drop.
Amazing.
Trying this
Yeah, it was a game changer.
Girl, there's your sales pitch. Yeah.
That's right. That's right.
I love it. Well, Dr. Lauder, this episode was, we went so many places in this episode. I'm really happy we got to touch on so many things, from like insurance and the traditional model to, energetics and, your masterclass and your book that's coming out. Like, we really did jam pack a lot in. So I just want to thank you so much for your time. I was like taking notes the entire time on this episode. I'll definitely have to go back and re-listen. And I do like kind of finish off every episode with a really positive note and ask every provider, what does it mean to you to live a vibrant life?
Great question. Let me look at my notes, because I had to write it down to make sure I had captured it. Okay. Vibrant life means that the safest place to be is connected to yourself, because from there you can go anywhere.
That was a quote I wanted to throw out there too. So I'm glad that you remembered and you said it for yourself, Dr. Lauder.
Yeah.
It's beautiful. I love it. And if anyone listening wants to connect with you, Dr. Lauder, or is interested in pre-ordering your book, or look into your masterclass, where can we find you?
Yeah, the easiest thing is my name, drmarylauder.com, drmaryllouder.com. And then Instagram, Dr. Mary Lauder, Facebook, Dr. Mary Lauder, YouTube, Dr. Mary Lauder. I just kept it really consistent.
Pretty easy.
And yeah. And so, we've got podcasts, we've got webinars, we've got lots of fun stuff happening. So check us out. Yeah.
We will be sure to make sure to link this down in the show notes for everyone listening today, so that they can find your website, connect with you. And to everyone listening and tuning in today, I'm wishing you all vibrant health and wellness. And until next time, take care.
Take care. Thank you.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness Podcast to discover the latest insights and strategies for optimal health. Join us again next week. Just a reminder, this podcast is for educational and informational purposes and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guest and host are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.